Okay, so understanding headaches. It's quite a large topic, but I thought I'd make it quite simple to start with, and the interaction will come in the back end of the presentation or the webinar. So, I'm a consultant acute physician by trade, and I was lucky enough to be a neurology registrar at Leeds quite a long time ago now, for a year. And I used to do a headache clinic. So a lot of my experience was honed there, and then it's been built on when I've been doing my day job, which is an acute medic. We see a lot of headaches, either at the front door when they come to A&E or when the GPs refer them in. So that's my experiential learning and how I'm going to apply it, hopefully, to help you guys as employees and employers. So headaches, I'm going to break down into headaches in numbers, different types of headaches, and then, what are headaches? When do we need to worry about them? When do we not need to worry about them? So some interesting facts about headaches in numbers. So, the slide's pretty self-explanatory, but 4% of the population report headache on more than 15 days per month. The rates are higher in women, which is actually to do, unfortunately, with a hormone profile, more than anything else. So that's the immediate impact on the general population of the UK. And all this information is from the British Association of Study of Headaches. An acronym is BASH. They're a fantastic service. And I refer back to them quite a lot. And part of my original training when I did neurology a long time ago was helping provide some of this information. So the workplace impact in the UK per year, migraine sufferers lose about almost 6 days of work a year, and that's 25 million days are lost in addition to diminished performance. So if you think about that, about your own, what you do and how you live your life and what company you work for, that is an enormous impact. And yet we don't seem to be getting it right for people that suffer with migraines, which I'll come on to in a little bit later on. The next step is, migraine sufferers avoid making complaints due to fear of cancellation. What does that mean? Oh, I've misspelled that. Double L. So what does that mean? Well, it means that people that suffer with migraine specifically end up changing their lifestyle because they don't want to upset other people, and it has both an impact at their work, but also an impact in their social life. So headaches are actually a problem, not just for an individual, but they can end up having an impact on people's socializing skill and actually on a wider length on society in general. And what you end up doing is getting isolated. And we know that isolation is not great because the pandemic highlighted that quite extensively. The other impact that is underreported is the home and family impact. So 50% of migraine sufferers are more likely to argue with their spouse or their kids due to the fact that they're suffering with a migraine. And a third of them would believe that actually they'd be better off, they'd be a better partner if they actually had their migraine managed appropriately, if it wasn't for their pain. So clearly there's an impact at home, there's an impact at work, and then there's the individual impact. So that, that well-being is being impaired by that individual with that headache. And in the UK, 6 million people aged between 16 and 65 have been affected with headache. And apparently, according to numbers back in 2014, they were reporting 190,000 attacks of migraine per day for that 1 year in 2014 in the UK alone. So again, this is migraine, which is a sub category of headache, which we'll come on to classification in a minute. But it just shows you the amount of impact that this has on all the different aspects of our life. So that's just a quick sort of headache in numbers. So how do we classify headaches? When I was trained, we classified them into primary and secondary headaches. And primary headaches, which account for about 95% of all reported headaches, are those that we don't actually know what causes them, as in like there's no obvious pathology to begin with. And secondary headaches are usually as a consequence of something else. And an example of a secondary headache would be a brain tumor, head trauma, a bleed around the brain, and those sort of things. Primary headaches, we break them down into tension headaches, which are very common. Migraines, which are the vast majority of all reported headaches, are actually migraine sufferers reporting their headache consultations to primary care, to GP. And then we have this other group called cluster headaches or autonomic trigeminal neuralgias, if I can say that with my teeth in. And they make up 95%. That tension headache, the migraine, and the cluster headaches make up 95% of all reported consultations in the UK with regards to headache. The more worrying ones only make up 5%. So you can see how common a problem it is, but also in the background, we've still got to be mindful that 5% of this number in total will have something to worry about that needs more expertise and intervention at secondary care or hospital level, if needs be. So the first bit is to talk about is tension headaches. These are very common. They are usually influenced by your lifestyle. And by that, I mean your sleep pattern, your eating pattern, how much fluid you drink through the day, whether you have a diet that's full of stimulants, full of neurotransmitters that aren't appropriate for you, i.e. sugar-free type stuff. These are common. They're very, what's the word? They can be debilitating, but they're usually quite self-limiting, meaning that they don't trouble people that much, because sometimes you can take a simple painkiller like paracetamol or aspirin and the problem tends to resolve. However, they keep coming back. And that usually indicates that your lifestyle probably isn't appropriate, and it's your body's way of telling you there's an issue here, you need to address it. And the common themes for tension headaches, or the common presentation usually is a band-like sort of squeezing and tightening. It's usually encompasses the whole of the head, sometimes the front of the frontal area, the front of your head, but predominantly it can be a tight band, and it can be associated with a bit of blurring of your vision. It can be associated with things being a lot louder than they should be, and they're not, but that's affecting you. And when you question people about their tension headaches, the underlying theme from when I see them, whether I'm doing the stuff I do at the front door or whether I'm in clinic, is that predominantly these people suffer with an irregular sleep pattern. So they may be, instead of getting 6 or 7 hours of sleep, they're only getting 3 or 4 in the preceding few days. They have a very poor fluid intake. So they'll probably drink about 1 or 2 cups of water a day, and they'll have about 6 or 7 coffees or teas a day. They tend to not exercise regularly. So they'll probably go to the gym once a week, or they'll go out for a walk once a week. And then they skip meals. So skipping meals changes the hormone profile in your body, which can end up causing tension type headaches. So skipping meals and watching your blood sugar fluctuate can affect the way that you present with a tension headache. So those are simple measures that people can do to make them less likely to suffer with a tension headache. So they're relatively straightforward and can be self-managed if you talk to the right person and describe what they are to you. The more difficult group, and the ones that make up 90% of all GP presentations of headache, are migraine sufferers. Now, this is a huge problem for primary care, because the amount of people that I used to see when I was a neurology registrar at the LGI, I think 3/4 of all the referrals I saw for that 1 year were down to migraine sufferers. And it was quite stark how a lot of these migraine sufferers didn't actually have migraine, but thought they had, and they just hadn't had the appropriate advice, and people didn't go into the right level of detail to scrutinize what their symptoms were. Now, with migraine sufferers, there tends to be a bit of a pattern. So they usually start when you're in late childhood, early adulthood. There tends to be a bit of a family history. But the most obvious thing is there tends to be triggers. And this only can be mapped out once you've suffered with a few. You tend to have a unilateral headache. It tends to affect your vision. You can sometimes have not auditory hallucination, but things become much louder than they should be. And then obviously you throw up. So there's usually intractable vomiting where you just can't control throwing up. That takes time to understand, because you suddenly start to learn that certain things are triggers, and the commonest triggers tend to be red wine, strong cheeses, chocolate, but also they're sometimes related to menstrual cycles. A lot of migraine sufferers, obviously female, don't understand this until they're probably well into their late teenage years and early 20s, when they suddenly realize actually there is a bit of a link. So the things that I look at when I'm talking to someone that's potentially has a migraine, I obviously ask them about photophobia, because the light sometimes tends to hurt their eyes. An impairment, as in they can't function. So if they're having a migraine, can they go about doing their normal job? Yes or no? The answer is no, then I count as an impairment. And then, are they sick? Are they throwing up? And that comes down to nausea. So the acronym I use is PIN. So photophobia, impairment, nausea. And if they're ticking all three of those boxes, then they are 99% obviously going to be having a migraine. And then I dig it a bit further if there's a family history, and then if they already know about triggers. So those are the sort of things that would alert me to thinking someone has a migraine. The rest of that ability to describe what they're suffering with comes from examining them, which tends to be normal. And I don't tend to scan these people. And by scan, I mean doing a CT scan, unless they have other certain red flags, which I'll come on to in a while when we talk about what to worry about. So for that there, I'm going to take a quick pause. Is there any questions about what I've described so far? Just find the mouse.
Sorry, yes. You mentioned about triggers, and I think you said sugar-free.
Yes.
Can you expand on that? You would think that.
Yeah. So without getting too, I'm not a neuroscientist, but there has been a trend over the last decade of people describing migraine attacks with Diet Coke, sugar-free 7-Up, sugar-free Sprite, and there's something to do with the aspartame in there. And aspartame is a neurotransmitter, and what I think, and I don't know the exact science of this, but what I think is the aspartame, the way it's transferred in the brain and the neurons, is I think it's ended up saturating the receptacle, the receiver where that neurotransmitter transfers to. And I think that might be enough to trigger the migraine. So if you're drinking excess amounts of these sugar-free things that's predominantly aspartame, then there is a link there with triggering your migraine attack. So my advice to these people is to cut it out for a month and see how things go. And, you know, I think probably about 80 or 90% of them, they don't have a problem once they've cut those things out of their diet. Is that helpful?
Yeah, thank you.
Excuse me. Anyone else with, well, let me just let this young lady in, sorry. Anyone else with it about tension or migraine? Because this is a huge burden. And the point I was trying to make at the beginning is that actually it's not a quiet burden, it's a massive burden for primary care, for GPs. And a lot of the GPs don't always get the diagnosis right because they don't have the time to get it right, but also they refer it on to us in the hospitals to see people, and we have a bit more time and we spend a bit more time talking to people. I think that's the key bit. A lot of patients or people that suffer with these headaches don't always get the right answer because they A, don't see the right person, or B, they don't get the right amount of time to talk to people. So no more questions on migraines or tension index. Cool. Okay. Right. So the next bit, do you suffer from headaches? So based on the things that I've just talked about, how many people here on this little webinar, how many of you are headache sufferers? You can unmute yourself and say I, and I can, because I've got a list of you here, so I can kind of see who's who. How many have headaches? 1?
I do.
2?
Yes.
I do.
3?
I do.
Yeah.
I do.
I do.
So is there anything that I've said to anything so far in what we've just, we've just touched on just the primary headache so far, very small proportion, that rings true or actually doesn't ring true?
Yes, it's hereditary for migraines.
Yeah, okay. And how old were you when you started, if you don't mind me asking?
In my 30s.
All right, okay. And is it on your mum's side or your dad's side?
Yeah, my mom's side.
Yeah.
She started in her 30s and my sister in her late 20s.
And what has been the impact, if you don't mind us sharing this, what has been the impact on your life until you realized you had migraines? Was there much of an impact or not?
Yeah, it's been really bad actually, because it affects my work, it affects whether I go out socially. It's been a struggle at the GP getting diagnosed, because automatically they were like, you just need to get your eyes checked at the opticians, and
Yeah.
That was always the thing, too much computer work, but it would happen with, like you said, triggers that would trigger it and so forth.
Yeah. So how did you come to the diagnosis of migraine then?
So after I kept complaining to my doctor and saying that I think he needs to look further into it, that's when he realised that the history of my mum and my sister also had the same thing, and they went through the same process. And then we looked at my diet to see if that was affecting it, and had to start making a diary to see what was that, and that's how I found out what the triggers were.
Yeah. So the thing I told you, the acronym PIN. So that, you know, I've used that for the best part of, when was I, Reg? God, 2008, I think. Since 2008, I've been using the acronym, and I'm pretty much spot on nailing people that have got migraine just by asking them, are they photophobic when these attacks happen? Have they have an inability to do their job when it happens? Are they nauseated when it happens? Then, you know, if you tick those 3 boxes, the likelihood is you are a migraine sufferer. The next step after that is to then recognize what the triggers are and try and alter your lifestyle without having to make any modifications with medications, because ideally we try and do it that way before we start introducing chemicals that you may or may not need, but also have other consequences.
Yeah, I think that is good, because the very first thing was, oh, here are some tablets.
Yes.
And I was like, I don't really want to live my life on tablets.
Yeah. Sometimes, you know, as clinicians, we sometimes forget that actually, you know, giving tablets may not be the best. You know, we try and optimize everything we can with lifestyle factors, because actually a lot of us now live lifestyles that are not they're not attuned to having a healthy lifestyle, if that makes sense. We live in a very work dominated, high pressure, high stress, high results requirement world, and that's, you know, everything we want. We do something, we want immediate results, and it's not always conducive to good health.
Yeah.
So yeah, so thanks for sharing. That's really helpful.
No worries.
I think that also highlights the benefit of seeing the right people the first time and getting the right input. So one of the reasons I've joined the We Are Wellbeing was to try and influence people's outcomes without them having to suffer and go through the NHS to do this. And it's something that myself and Andy have talked about how we get people to access me through We Are Wellbeing, so we can help not just the employee but the employers as well as a consensus. And it may be that we probably take this a step further and try and do some kind of interventions, but we'll see. Okay.
Sorry, I've got a question. You
Yes.
said like migraines can start when you're sort of when you're quite young, and it could be
Yes.
sort of hormonal. So as you get older and you're no longer having menstrual cycles, would you expect your migraines to get better or disappear if you're not in that cycle anymore?
It's a good question, and it is a hot topic because menopause and headache is quite an unknown area in inverted commas, because I'll be honest, in the medical world, the vast majority of studies over the last 100 years have all involved 70-kilogram white males. So we haven't done much research into anyone that's a woman or of ethnic minority for any of the major studies of any aspect of medicine for the last 100 years. So any evidence out there isn't always great, and it doesn't reflect the appropriate populations that now are coming forward with problems. That's just the backdrop. The bottom line for me is that as from experience, I have seen ladies when they reach a certain age suffer less with migraine, but consequently, some people have been re-referred when they've started to develop other headaches based on the changes that they're going through perimenopausal. So perimenopausal, obviously you're in and around the menopause, you're still having your periods, but your hormone levels at that stage could be doing all sorts of things. So it's quite common to see, well, I've seen it a few times, not common, I've seen it a few times where I've had to actually restart anti-migraine treatment, but only for a year. In the 2 people I'm thinking of, they came back a year follow-up and they didn't require them anymore. So once they'd gone through the menopause, their issue with migraine actually diminished. And I think I followed them up for about 3 years before I moved hospital. So, and then I discharged them. So they didn't have any issues post-menopause with migraine. But that doesn't mean that's the case for everybody. It's just for those two ladies. And it was almost identical. You know, perimenopausal things got worse because they managed to modify their lifestyle and they got a lot better. Perimenopause all came back again. And then within a year of me seeing them and changing them and putting them back on, I think it was topiramate I used for those two. Anyway, they didn't require it anymore, so they came off it. But that doesn't mean that you'll be the same. Sadly, these things are quite
Okay.
different.
Have to suck it and see then.
Well, yeah, was that a Solpadol advert? I'm sure that was a Solpadol advert. But yeah, that is sadly that is the case. And sometimes, and that's why keeping a diary. I know it sounds a real pain in the bum keeping a diary, but actually, when you're suffering with these chronic problems, looking back and trying to identify things is only useful if you've kept the right level of information. And sometimes we don't always guide people on what the things are to look for and what to take note of. And I still, I'm not a neurologist anymore, I'm an acute medic, but some of it is that we're just because we're experts doesn't mean we know everything. So I used to rely on patients, and still do, on them giving me what they think is actually driving some of this and not ignoring that. So the key point I'm trying to make is, if you're keeping a diary, put as much detail as you can in it, and don't think what's the doctor want to hear. Just write down what you think is relevant, because that's the bit that's relevant for you, and that may be different for everybody.
Okay, thank you.
Does that make sense?
Yeah, it does. Thank you.
Cool. Okay. Anything else that anyone else wants to share on just what we've talked about? Because migraine is a big patch, and I don't want to get into treating it. I just want people to be aware of it and understand that it is a problem that simple lifestyle measures can make a difference to, first of all, by differentiating the people between tension headaches and those with migraines. Because the next bit I'm going to talk about is about red flags, things that when we should get worried and what we should do about it, which is slightly different to what we've talked about already. So no other takers what we've talked about already. Okay, we'll move on. So, do you know what's causing your headaches? Now, as we've alluded to, with a little bit of knowledge now, you can identify a tension headache compared to a migraine. But there are certain headaches that you absolutely should not ignore, and you absolutely should go and get medical advice for. And the one that comes top of the tree when I'm down in the A&E is something called a thunderclap headache. Now, this headache is one that comes on like that, back of the head. You feel, and the classic wording in the old textbooks was, you feel like you've been hit with a shovel across the back of the head. Now, I don't know many people that have been hit with a shovel across the back of the head, but I've been hit with the back of the head for other things, and it hurts. So when that happens, the one diagnosis that every doctor wants to make sure they don't miss is something called a subarachnoid hemorrhage. And the reason I'm sharing this with you is because a subarachnoid hemorrhage is not very common. However, a thunderclap headache, which is what this is very common. And the reason it's common, sorry, I'm just trying to think other people in. The reason it's common is that there are other causes of this, and it's important to get those identified earlier rather than later, because if you get something called a subarachnoid hemorrhage, that is literally a bleed around the brain. So a vessel in the lining around the brain can pop, and when it pops, it can be quite devastating, with the ultimate outcome of causing death. So we don't want to miss it. So the question here is, when do I need to go to A&E, or do I need to go and get an urgent appointment with my GP? Well, if you suffer with a thunderclap headache and it happens, and you feel sick with it, and you vomit, and your sight is altered, and you think, I can't quite focus on stuff, and you've still got that pain, and it's a 10 out of 10 pain, the worst pain you've ever had, that essentially is when you should be going to ideally the A&E and telling them that I think I have a thunderclap headache and I might have a subarachnoid hemorrhage. But honestly, you won't be able to speak properly because you'll be throwing up, and some people can get quite confused with it to begin with. So that is an absolute red flag, and that's an acute problem. Now, thunderclap headaches can also happen, and this is where we'll probably start to snigger a little bit, but you can get it through coughing too much. So at the moment, I'm suffering with a bit of a cold. It's been dragging on for ages. And 2 or 3 days ago, I had an intense headache every time I coughed. Now, that's because the pressure inside my sinuses and around my brain had changed, because I've got lots of mucus. And every time I cough, I felt like I was getting hit on the back of the head. But I knew that it's not a thunderclap headache caused by a bleed. It's actually because of the pressure change in my sinuses and these things called the eustachian tubes, causing almost like, well, it was literally like someone had hit me on the back of the head every time I coughed. So it's the coughing that did it. Now, a similar type of headache can happen through exertion, and the exertion may be exercise or sexual activity. And this is the bit where, as a neurology registrar at Leeds, I saw quite a lot of in the A&E out of hours, predominantly out of hours, where both male and female patients were presenting with sudden onset thunderclap headache during sex, so coitus. So at the point of climax, it is not uncommon, and there is about, I think the literature states about 20%, a 20th of all cases of thunderclap headache are related to coital headache. So if you're ever in the point of climax and you suddenly get a sudden onset of thunderclap headache at the back, it sounds bizarre, but you need to pack up and leg it to A&E in inverted commas, with the concern that it might have a subarachnoid hemorrhage. But the likelihood is that it may be a normal consequence of that post-coital headache. I saw it a lot, and we ended up scanning a lot of people because sometimes it's quite difficult to differentiate when it is a bleed and it's not, because the people are quite distressed in trying to give you the history. So my advice would be that if that happens, you just go to A&E and tell them you have a thunderclap headache. And I think there's lots of pathways in all the major hospitals I've worked in. There are clear pathways for patients to present with this type of headache, and they try and pull them out of the departments. You're not waiting for long periods of time. The other bit, the exercise bit, is if you have not drunk enough fluid and you're exerting yourself at extremis, as you exert yourself, you sweat, you lose a lot of body fluid, and what your brain does, or your body does to protect the brain, it changes the pressures in and around the brain and the fluid within the brain to try and make sure it stays in the same environment. And in doing so, that change in pressure, because you've not got enough fluid on board, can start to cause something called an exertional headache. And that tends to be thunderclap in the extreme cases, but generally, on the whole, it tends to be a generalized headache. And obviously the cure for that is proper fluid hydration, and not just water, but you need to add a bit of salt, a bit of lemon to that to allow balance, because the constitution of the brain fluid is slightly different to the rest of your body. So drinking lots of water may not be helpful, because that ends up causing lots of shifts of fluid that actually make the headache worse. Without getting too complicated, if you're exerting yourself exercise-wise, you've got to make sure you've got enough fluid on board to begin with, and then enough appropriate fluid, i.e. salt-based fluid, going in afterwards to replace what you've lost. Otherwise, you will end up with a headache that may be generalized, but can become a thunderclap if you start to continue to exert yourself and you've not replaced that fluid that you've lost. Does that make sense? I'm not looking at no faces. I'm not very good at this webinar stuff. Does that make sense so far? If someone just say yes or no, that'll be good.
Makes sense to me.
Yeah. Oh yeah, a couple of thumbs going up. Excellent, cool. Okay. I'm just mindful that I'm always mindful that if I start talking too much, I could end up turning it all into jargon. I don't want to do that. I just want to make it so it's still applicable to people that are headache sufferers and they've got questions. So those are the acute headaches that you need to worry about. Now, the other one, which is a slightly different scenario where you do need to get medical attention, are the more chronic headaches, but they have certain red flags. And these red flags are probably where I think it was one of our colleagues here that was talking about migraine, where the GP said, oh, you need to get your eyes checked. Now, the reason they say that is one of the first features of a concerning pathology within the brain is a change in the back of your eye. And the change at the back of your eye is something called papilledema, where there's a swelling of the optic disc. Now, that is a sign that there's raised pressure within the brain, and that is a big red flag. A lot of the referrals that I get into the service come from the ophthalmologist or even directly from the opticians, where they have a hotline to us and they ring us and say, I've got a young lady, she's got a blurring of a disc. It looks grade 2 or grade 3, and she's had headache for a week. So we get them in and we sit down and we talk them through things. But that swelling of the disc is something that needs urgent attention. Now, you may have presented with a headache already to your GP, and your GP will have sent you to the opticians and they'll have a look in your eye. Good GPs, like my old man about 30 years ago, he would have looked in the back of your eye and been able to diagnose the fact your disc is bigger and swollen. But we don't have those sort of GPs anymore. Everyone seems to not have time to talk to people. So what they do is they send you on to either an eye casualty, where they'll look at the back of your eye, or the optician. The other features outside of the eye are actual seizures. So you can, if you start having seizures completely out of the blue, it doesn't necessarily mean you've got epilepsy. it can be a sign of other things. And one of the worrying things is that there is something structurally wrong with the brain. And the thing I'm leading towards here is if you've got something that's changed the swelling at the back of your eye, changed the optic disc and it's become more swollen, and you've got something that's changing the electrical activity over your brain, because that's what a seizure is. A seizure is when the electricity gets stuck. Then there is something going on within the pathology of the brain. And that worry is it a brain tumor? Now, they can be primary brain tumors, or they can be secondary that have spread from elsewhere. And if you have papilledema, that's the posh word, or swelling of the disc at the back, and you have blurred vision, or you have a new seizure, or you start to become confused intermittently, or every morning when you wake up for the best part of a week or two and you're throwing up every morning and you're waking with that headache, then you need to be getting yourself to your GP as soon as possible, because those are the key red flags that we'd be concerned about for pathology that's malignant within the brain, i.e. there's cancer in and around the brain. Now, this never used to be very common when I was a trainee doctor, but over the last decade, they have become more common because, well, multiple reasons, but there are other disorders that can present in this way that aren't a straightforward primary brain cancer. So lymphomas, sadly, when did I do my lates the other week? Two younger adults in their early 30s came in with seizures in the space of 48 hours, both of whom look like they've got lymphoma. And that's an abnormality of the drainage of the lymphatic system, but it can start by having an abnormal growth within the brain. And we're seeing more and more of these things now than we did 20 years ago. So you need to be mindful of either colleagues or yourself that are always complaining of headache, that are vomiting, that aren't themselves every now and again, or even family, more important, probably family members more than anything, and new seizures. These are all red flags that you should not ignore. And sadly, one of the people I saw the other week, they did ignore it for the best part of 2 weeks. They'd actually still they'd had a seizure and they'd still continued to drive as well, but that's a whole different kettle of fish. So those are your red flag features. Those are the things you should not ignore, and you should seek urgent medical advice. And to be honest, for the acute stuff, we get the thunderclap, that should be A&E. This stuff is much better suited to your GP at the first point of contact as an urgent appointment, because it may not always be what the worst case scenario is, but it's a better use of their time. Now, GPs I know are difficult to get into, but if there are concerns about a primary problem within the brain, then that's the way you should try and express what's wrong with you. Any questions on that? I'm mindful that I've thrown a hell of a lot at you with the acute and the chronic headache type stuff there.
What did you say it was called again, please?
Which bit?
You said the official word for it. I think it began with P.
Papilledema,
That's
the
it.
swelling of the disc at the back of the eye.
Yeah.
Yeah. So that papilledema can be caused by lots of things, but the thing we concern ourselves about is that raised pressure within the brain. Yeah, because you can have raised pressure within the brain and it not be a cancer. And it's actually, again, more common in ladies, usually ladies that are overweight, or usually ladies that are overweight with high blood pressure. And the only symptom you get is a headache. And then when you look in the eye, there's a swollen disc. But that's manageable. That's easily manageable. And that's very different to having a tumor in the brain. But it's papilledema is a red flag. So it needs to be seen urgently. But you don't know you've got that half the time unless you've started noticing changes in your vision or you're suffering with a headache, which is why this links into the headache bit. Any other questions? Okay, so I'll move on to the last bit, which is it says expert recommendations, but actually a lot of it's common sense. So if we try and park all the horrible stuff we just talked about, the 5% of problems that we just talked about, and go back to the stuff we talked about at the beginning with regards to your migraine and your tension headache type scenarios, then actually for the tension headache, simple things are preventative. So getting enough sleep, and by sleep, I mean good quality sleep. And by that, I mean not just your core sleep, but your deep sleep. There is evidence to show that those people that can achieve at least a couple of hours of deep sleep a night tend to have no issue with tension headaches. Exercise, another treatment plan for people that recurrent tension headache. And this, you may laugh, but I have prescribed exercise to a persistent tension headache sufferer, where I gave him an exercise program, and he was in his late 40s, yeah, he must have been. And I prescribed him to join not a HIIT class, but just a spin class, a light spin class for 3 times a week to help him, because that the exertion that comes with exercise, if you're suffering with tension, actually is part of the treatment. Don't ask me about the physiology of it, because it gets me confused every time. But essentially, good sleep, good exercise, good hydration. And by good hydration, I mean you need to be drinking at least 2 litres when you're well and 3.5 litres when you're unwell, will help manage your symptoms better, and also hopefully prevent you getting those things, getting the tension headaches. With regards to eating, there is clear distinction between eating habits and tension headache sufferers. Skipping meals, intermittent fasting when you're not well, all lead to tension headaches. So you need to be mindful of when you're doing your intermittent fasting, because it seems to be all the rage these days, even though I'm not a fan of it. So you need to be mindful that you're well when you're doing it. And when you are doing it, you're getting enough fluid in. If you become someone that's very busy and stressed at work and you start skipping meals, I can guarantee that you will suffer with tension headaches for at least half of each month that you do that. And the answer for that is to stop, rest, digest. And you have to have these periods of break in your day to eat properly, not eat under pressure and eat under strain so you don't digest it properly. Otherwise, you will continue to precipitate your tension headaches. And this sounds really basic, but these are the best measures. The risk you have of ignoring these simple measures is that you then become reliant on painkillers. And when you use lots of painkillers all the time for headaches, you end up getting something called an analgesic headache. So that's overuse of painkillers, simple painkillers, usually aspirin, ibuprofen, and paracetamol. When you overuse them, you actually create something called an analgesic headache. And then the treatment for that is to stop them. So you stop all the painkillers, and then miraculously, person's headache goes away, that headache, because it's a different type of headache. And what comes back is their tension headache. So then they start again, and they start taking all the painkillers again, and then they get an analgesic headache. So it's important to understand that if you don't get the lifestyle changes right, you could end up causing more problems with yourself by using analgesia inappropriately. And that's trying to explain that to people takes up a lot of time, because they don't quite see it, because they're too busy thinking about the pain that they're suffering with, as opposed to taking a step back and seeing the wood for the trees. So that, that's quite an important factor, is when you're in pain, you lose the ability to look at things in the right light. Anyway. So that's sleep, hydration, eating, and then stress management. So stress management is something that I suffer with. It's probably why I'm so run down now. And trying to get that balance between not letting your work affect you, not taking your work home, giving your brain time to switch off, so it's not constantly firing off on all cylinders, is one of the root causes for a lot of medical problems that we see in secondary and tertiary care, so in the hospitals. And explaining this to people, again, doesn't seem to have the same gravity as putting people on medications, when a lot of the problems that we have in Western medicine, they don't exist in the East, where they don't have the same infrastructure, they don't have the same work pressures, they don't have the same lifestyles. So a lot of the disorders are quite specific to certain countries because of the way we live our lives and the way we work. So it is interesting that we're more and more turning towards ways of doing things differently than actually other countries do normally. The obvious things are the way that our hormonal patterns are set up as human beings is that actually we're geared to work from 5 till about 11 in the morning. Then we have a bit of a break where we eat, we have a bit of a rest, then we perform again between sort of 4 and 8 o'clock, and then we're done. That's the way our hormone pattern was set up from when we were hunter-gatherers. And a lot of countries still do that because they don't have a choice, because the hostile environments they live in don't give them any other way of working. And yet here in the West, or even in some developed parts of the East, we try and churn as much work out of people, pile the pressure on them, change their lifestyle to what they think is constructive. And what we're ending up doing is causing more problems medically for stuff that was preventable. So a lot of the things that we see at the front door, a lot of them are preventable if people are educated in the right way, and then they apply that education to the way they live their life. That's probably my take-home message for the day. Right, I think I'm done. Any questions from anybody? Sorry if I've rambled on a little bit.
Sorry. Thank you for going through all of that. It was really interesting. I think there's just so much to understand, probably can't fit into this presentation.
Yeah.
Do you work with the organisations? Because obviously I think some of us, I don't know if all of us got the referral of your presentation via our organisation. So are you working with the companies? Do you
I joined, and so there's a bit of a sales pitch, is it now for me? So I'm now the medical director here at We Are Wellbeing. So with my 20 odd years of experience, I hit a bit of a brick wall in the NHS at my level, pretty high up from a strategic level, and I'm getting very frustrated in the way that we're not helping our population. So I thought, how can I help people in a different way? And this is. I mean, Andy sat and talked to me about what he thought, how he could use my quite diverse set of skills. Because you don't often get someone that's a strategist that's also a hands-on acute medic on the front line, seeing people still. So part of my passion is to try and make people do better for themselves with some appropriate consultation. So I'm the medical director here at We Are Wellbeing, and we're in the process of putting together packages where we can try and deliver stuff to employers and employees to improve their health, specifically with certain medical conditions. So only this morning I've spent a couple of hours with Rachel doing some social media clips about long COVID, about liver disease, about the benefits of having the well man, well woman checks done, as well as a blood test, because then you'll have an expert like myself to then review them and potentially feed back to you directly what needs to be done and how it could be done. So that's in a nutshell. Is that helpful?
Yeah, that's great. Thank you.
Anyone else? Anyone got any questions on any of the topics we've touched on? Because we've touched on quite a bit. There's some things I haven't touched on, like cluster headaches, which I suffer with, and I've suffered with even more since I've had long COVID. But that's a different time for a different topic, of which I probably will do. I'll do something on long COVID, because that is a huge burden that's probably going to impact on our workforce for the foreseeable future, and the government doesn't seem to be providing enough help on that. But cluster headaches are a big issue with people that have something called autonomic neuropathies. Again, stress related, but we don't do much to help manage our stress consistently. Right, if that was helpful, I'm glad. If it wasn't helpful, please let us know how it can be more helpful, because this is the first time I've done something like this. Normally when I do presentations at Royal College, it's in front of lots of people, as opposed to doing it via webinars.
For me personally, it was very helpful. Thank you so much for all your advices. All my life, I thought that I was suffering from migraine, and this is because my mother has a migraine, and my grandmother. But now when you start talking about the quality of the life, I'm thinking that I have to change my lifestyle. So I don't do enough sport, I don't drink enough water, I don't like food, so I eat, but not that's all the problems that you said, that I think I have to change everything. I like chocolate, so I eat a lot of chocolate, which I have to stop. On top of this, I'm very slim as well. So I'm not sure in my case if this is actually a migraine, or I have to change everything. And I had the same problem as well. I took even before quite regular, almost every day, paracetamol or some painkillers. So at the end, I reached to the stage that after when I took this medication, immediately after 5 minutes, I start to feel, oh, I don't have this headache anymore, which means that this is psychologist side. And and then I stopped for 2-3 weeks. I didn't have, after I don't know how many days, I didn't have any headache. Then after one period, I started again with this. For me, I think that I have to change my lifestyle, and this was very, very helpful. Thank you so much for these advices. I'm not sure if it's migraine. I don't know what is this, but I have to change something.
Well, for you, it sounds like it's multiple causes for you,
Yes,
really.
absolutely.
And that's the other thing that we forget about. It's not always just one. People don't just suffer with one type of headache. I mean, there's a whole bit about the classification, because a lot of people do suffer with more than just the migraine. They may suffer with tension headaches on top of their migraines, or they might just suffer with a cluster headache on the background of having tension headaches. And that people do suffer with different types of headaches. But I thought, giving an overview and the sort of things that you can do for yourself to try and minimize the risk of each of those, or then make it clearer what you actually do suffer with, and you could sort of be in charge of your own health a bit better then.
Yeah, thank you. What is exactly the cluster headache?
So cluster, I can tell you myself, I only had one the other week. So cluster headache is unilateral. So it means it usually affects one side of the head.
Mhm.
And what tends to happen is you get a pretty horrible, excruciating pain that comes on. Your eye just starts watering and it does not stop. It just goes for usually between an hour or 2 or 3 hours. You'll feel really miserable. You cannot hear much on that side of your head. And you tend to have that side of your nasal passage, that sinus tends to be congested as well, a bit like I sound at the moment. And they can come and last for about 2 weeks, and they can keep coming back.
Yeah.
And they can keep coming back with usually a stressful trigger. So, for example, I did that week of lates where I broke some pretty bad news to a few people. The day I finished that week of lates, when I went to sleep, I woke up with my eyes streaming, my nose blocked, and an unbelievable pain in my head. I knew immediately that I just run myself down and this is a cluster headache. And then it's a matter of, right, I need to take my lenses out. I need to not do anything. I need to drink plenty. I need to be as quiet as I can. And then it passed, and simple analgesia. So for that, I just took Brufen. And the eyeball feels so sore. It feels like, I mean, I've lacerated the front of my eye a few times. So it felt like every time you close your eyelid, it's like there's grit just scraping down the front of your cornea. And it is horrible. And we used to treat it when I was a very junior doctor. We used to treat with lots of high flow oxygen. So if people presented with that, we used to give them high flow oxygen for about half an hour, and then miraculously this got better and they went home. But when you're at home and it happens, no one has high flow oxygen at home. So the simple measures are dampen down, get quiet, rest, remove whatever stress you can do, drink plenty of fluids, take simple analgesia. It will get better, but it will last a couple of hours. But it'll keep coming back in waves. But the cluster is the bit that it clusters for about 2 weeks if you don't sort yourself out. And then they keep coming back every time there's an appropriate stimulus, is how I describe it. But I wouldn't wish it on anybody. But what I've learned is in long COVID, so now I'm sadly, unfortunately, affected by long COVID quite badly. And it's more common now. So I get it more commonly now, or much easier now than I used to before. And I've suffered with them since I've been a consultant now, since 2010, 11, I've suffered with cluster headaches. When things get quite stressful, I tend to get one. But now I seem to get one every time I'm a bit run down. So yeah, they're not nice. They are self-limiting. I mean, without worrying too many people, they can be associated with malignancy if you're getting them all the time. If you're getting them all the time, you need to have a brain scan. But I'm not having them all the time. I just know when they're triggered. But then that's the important bit. You don't want to be going and getting head scans, because part of my concern and part of what's happening in the world now is the amount of radiation we give to people is actually probably causing quite a lot of abnormalities in people, and that's the balance we have to find. When should you be scanned? When is it appropriate? And when shouldn't you be scanned? And that's the bit where the NHS doesn't work very well, because we're scanning everybody all the time and not finding problems. And actually, fast forward 10 years down the line, we're finding more blood-based cancers. And there's definitely something to be said about the amount of radiation that we face as human beings in the Western world that's having an impact on the rates of cancer. When I was a trainee, it was 1 in 10 people you knew would have cancer. When I was a medical student. Then when I was a trainee, it was 1 in 6 people you know will have. Now it's 1 in 2 people. Every advert you look at, 1 in 2 people will have cancer. It's like in the space of 25 years, cancer in the Western world has just come to the forefront. And yes, we're living longer, but there is definitely something about our lifestyles, the way we live our life, how we do, what we do, the amount of interaction we have without nature. These are all factors that I think you cannot ignore. Anyway, I'll stop ranting. I've just realized I'm ranting and I'm going over. So I'm going to close it to a draw there.
Thank you.
Thank you.
No problem. Thank you, everyone. Thanks for joining.